Good afternoon. I'm going to be presenting a diagnosis of chronic granulomatous disease, and then I'm going to discuss our 30-year experience managing patients with this entity. This talk is sponsored by Horizon Therapeutics, and I'm being compensated for this presentation as a member of the Horizon Therapeutics Speakers Bureau. Chronic granulomatous disease is a rare inherited primary immunodeficiency in which neutrophils can engulf bacteria but can't kill them by making a respiratory burst and by making hydrogen peroxide, which is essentially what kills the organisms that are entrapped in the granules. So you end up with severe recurrent life-threatening infections. You can also get non-infectious granulomas that are triggered for reasons that we don't understand. And this can lead to non-infectious complications, such as an inflammatory bowel disease sort of colitis. The infections that we see are caused by the bacterial and fungal infections that you can see here on the slide. The 5 most common bacterial infections are Staph aureus or Caldera, which is often a cause of death in these patients, unfortunately, Serratia, Klebsiella, and Nocardia, as well as the fungal infections of Aspergillus and Candida. There are 2 forms of the disease, an X-linked form and an autosomal recessive form. The X-linked form is generally worse, and it's typically diagnosed in childhood, although we occasionally diagnose patients in their teenage years, and there have been reports of diagnosis even in young and middle adulthood. When the disease was first described, almost all children died by age 5 or 6, but once treatments started to become available, at least 90% of children will survive into adulthood. Liver and lung infections are common in CGD. It's also very common to get lymph node infections. The non-infectious complications that we often see can include colitis, as already mentioned, as well as obstructive uropathy and obstructive syndromes in other parts of the body, such as exiting the stomach. CGD is diagnosed these days generally with a flow cytometry test using DHR. DHR is a fluorescent dye which is sensitive to oxidation and hydrogen peroxide formation. So what's done is the flow cytometry machine can pick out which white blood cells it wishes to study. It takes the neutrophils, and then they're stimulated, and then the machine measures whether the dye is fluorescent inside the neutrophils or not. So you can see in the upper left-hand corner an example of a normal subject whose unstimulated cells are represented by purple, and they don't really fluoresce because, as you can see, they're towards the low end of the curve. But the yellow curve represents the stimulated cells, which are fluorescing several hundred-fold over baseline. Normal is over 30, but normally in healthy people can be as high as several hundred, as you can see here on the slide. In somebody with CGD, in the lower left-hand set of graphs, you can see that the purple and yellow curves are essentially superimposable because there's no fluorescence in the diseased neutrophils. In an X-linked carrier of CGD, as you can see in the upper right-hand graph, you'll have 2 populations of cells, one of which is normal, one of which is abnormal. And finally, in autosomal recessive CGD, you might have a slight bit of fluorescence, but not nearly enough to be considered normal. Therapy of CGD consists of prophylactic therapy with antibiotics and antifungal agents. When the disease was first described, as I mentioned, the children were dying at very young ages. People started using antibiotics, and the children started to live longer. Many retrospective studies by the early 80s show that Bactrim was a very effective prophylactic agent, and that's become pretty standard to use as antibiotic prophylaxis in patients with CGD. Because of the high risk of fungal infections, many people started to use azoles to try to prevent infections in patients with CGD. And in 2003, a paper was published in the New England Journal of Medicine, also a controlled trial, showing the efficacy of itraconazole. So itraconazole is often the azole used to prevent infections with CGD. There's also immunomodulatory therapy that's been available since a controlled trial that was published in the New England Journal of Medicine in 1991. So just to review our experience, we published a paper in 2015, which reviewed our experience through November of 2013 in patients with CGD. We had 27 patients in that publication. We then have updated our experience for the next 6 years. We now report on 26 patients. The reason for the slight difference in numbers is, of course, that some of our older patients have graduated to adult practitioners, which is a good thing, and we've acquired a few younger patients and newer patients, as the patient I described in this report. All 26 patients are alive. 3 had undergone stem cell transplantation in the last 6 years successfully. Nobody has died in the last 6 years in our population, thank goodness. We had 3 deaths prior to that, before 2013. So our mortality rate compares very well with what's in the literature with medical therapy. And our most recent serious infection rate. So serious infections are a little bit hard to define. They're generally defined as infections that require either IV therapy or hospitalization. Our serious infection rate has declined over the last 6 years. So when you include our last 6 years data in aggregate, our rate becomes 0.2 per patient per year, which compares very favorably with what's been in the literature since the year 2000. Thank you for your attention. I'm happy to continue this discussion at the hours mentioned on the slide.